come first. Yeah, it leads before respiratory. Okay. Cardiovascular is very important. So chest pain and palpitations. If a person comes to you with fever, cough, mild shortness of breath, chest pain, okay, go. The diagnosis is completely different. That is completely cardiac. You won't be thinking of upper respiratory infection or a mild cough or flu. If the chest pain is there, then you have to rule out via ECG. You have to find out if the palpitations and chest pain are there. You definitely have to take an ECG to see if the rhythm of the heart is normal. Okay. Okay, that is one system connecting to fever. Respiratory, again, like I told you, cough, shortness of breath, running nose, they are very connected. Again, ask for diarrhea. If whenever you ask questions about gastroenterology system, think of appetite, think of weight gain, weight loss, think of vomiting, think of diarrhea. Okay, diarrhea, make the person explain in their own words. Sometimes just passing the stool very fast, twice a day, they will say, I have diarrhea, doctor. No, that's not diarrhea. That's a quick, soft stool. That's not diarrhea. But if they have a lot of purging water, frequent, a little mucus, sometimes blood stain, that is diarrhea. Okay. So always don't prompt them when they're describing about diarrhea. You have to get the person's version of what they think is diarrhea, and you'll be amazed. Sometimes it's not diarrhea at all. It's just a loose stool that they've had or mild dyspepsia. Okay. When it comes to the genitourinary system, always ask about discharge. Always ask about pain while passing urine. Fever with pain while passing urine is definitely urinary tract infection until proven otherwise. Okay, skin rashes. Fever is very common to present with skin rashes. Like COVID patients, we are seeing almost 30 to 40% of them after the vaccination, or they have come with rashes. Yeah, so skin rashes are definitely connected with upper respiratory. Joint pain with fever. If they have joint pain with fever, always rule out, chills and rigors, rheumatic fever, or is it septic joints? All septic joints will always present with chills and fever. Coming to the brain. If a person comes to you with fever, headache, and stiffness of the neck, they say, I can't lift my neck like normal, doctor. Be very careful. Neck stiffness is the most important sign of meningeal irritation. That means that's the early sign of some inflammation happening in the layers of the meninges that are covering the brain. And it's a very serious complaint. If somebody complains, even babies, the baby is holding herself stiff when she's crying, and you try to lift the head and fold the baby, or try to make the baby sit up, and the baby winces and cries, be very alert. That is the earliest sign of meningitis. So meningeal signs means the person needs admission, regardless of what the other symptoms might be. If a person comes with fever, neck stiffness, they definitely need to be admitted to be investigated, because meningitis spreads very fast. Babies can die within hours, sometimes 4 to 5 hours, and they're gone. Yeah, elders hold on for a while. Adults can hold on to meningitis for a while, but the sequelae of untreated meningitis is so bad. They can have paralysis, they can have brain damage. So if you don't pick it up early, we'll be deemed negligent. Okay. So neck stiffness is a very important sign with fever. Remember, with fever, like I told you about chest pain and palpitations, neck stiffness. Okay. Of course, headache and paresthesia. ENT, of course, classically, all the symptoms, if there is an infection in the ear, it will all be related to the ear. They will talk about giddiness, they will say discharge, or they will say pain in the ear. Everything is around the ear, or ringing sound, tinnitus. So then you know definitely there's an ear infection. You need a complete examination, maybe an audiometry. If the ear looks dry, then you have to refer to an ENT specialist. Okay. Lastly, not far away, just 2 slides more. Other medical history, I said medical and surgical history. Drug history. Drug history is very important. If a person has already taken a course of antibiotics, if a person is allergic to certain drugs, then that guides you into treatment. Family history. Always respiratory infection will have at least 1 or 2 members having a running nose or cough at home, or person who's just recovered from a cough and cold, things like that. Or a person who just traveled, came back from Umrah, came back from a holiday, and then he was coughing. I also got the cough. So family history, especially about people coming in and previous members affected with URTI, is very important. social history, you all know about smoking, alcohol, recreational illicit drugs. Okay. Lastly, before you finish the consultation, it's always important to give the person, the patient in front of you, a chance to to explain what are his concerns. It's amazing. Um, in every consultation skills module, we teach ICE. Yeah, ICE is ideas, ideas, concerns, and expectations. Okay, what are ideas? This person thinks this cold is because I had ice cream yesterday, doctor. I had a big tub of ice cream. Okay, that's his idea. You might find it funny. You might say, where is ice cream connected with sore throat? But fine, that's his idea. So you ask him, what do you think this brought on? Then they'll give you funny ideas. It's okay. That's the person's idea. Concerns, what do you think this will lead on to? Do you think the sore throat is something to worry about? Do you think it will heal with home remedies? Then that's when you can explore person's perspective about management of minor illness. If you say, yes, doctor, every time I get the sore throat, I go to the nearest GP and get a course of antibiotics, then you know that this person is misusing medication. So you have to tell him, no, that's not the right way. So this builds up by exploring a person's ideas, concerns, and expectations. What you're going to expect from your consultation will be very easy. So you have to design your answer according to this, what you get out of this perspective. So you have to address the person's ideas, you have to address the person's concerns, and you have to make sure you reach the expectations, but you don't have to comply. If the expectations are something beyond your medical means, you have to say, okay, I'll hand you over to a specialist. But if the expectations are something which you can deal with and say, no, you don't actually need to see an ENT specialist, you don't actually need antibiotics, then you can deal with it in this consult itself. Okay, so it balances how you're going to close your consultation. So always explore the ICE model in every consult. It's very important to check what the ideas are, what their beliefs are, what concerns a person, and what they think is going to be serious and stuff like that. And of course, be sensitive to find out how it's affecting their daily life. Is it so bad that they can't go about their work? Okay, then that's a reason where we'll give them a sick leave. But if it's something they can go about with happily, then you'll have to explore and tell them, sorry, it's just a mild cold, take some vitamin C and some Panadol and you should be back to work. Yeah. This COVID time, we're having a lot of difficulty saying that because every person who comes in with even the mildest of URTI symptoms, the CDC rule across the world is swab them and check. Okay, so people are misusing that. People are coming in for repeated sick leave and we find it very difficult. Anyway, finally, we're coming to the last stage of the consult. When you're the very skill in finishing a consultation is how well you summarize it, how well you get the major points out of a conversation, you make it into easy language and give it back to the patient. That is summarizing. Whatever you understood and what you want to tell the patient. Yeah. Safety netting. Sometimes patients will ask you things that you can't manage. You practice safety netting. You just tell them, I'm a first year student. I've been just asked to ask your history. This information that you wanted, I'll hand you over to the seniors later. They will answer it or something like that. Always thank the patient for their time. Thank you for the time for letting me talk to you. And let them know that since you're a junior, you will have a senior doctor coming in to see them. Make sure the right box is very important. You must be very organized, systematic, and also make sure your time management is. You can't just sit there and say, hey, Dr. Parveen said, listen, listen, listen. So first 15 minutes of the conversation, I'm going to just sit and listen. No, you have to make sure you do time management. Yeah, sometimes patients can rattle on. They're very happy. They look at a nice young doctor, very keen to listen and talk to them. They'll go on. They'll tell you stories from their grandfather's time. So we can't allow that also. So you have to be very careful about how you manage your time and close the session appropriately. Sometimes if they go beyond that first complaint, they talk about something else, you can tell them, I'm sorry, I have to go back to another consultation. I can't spend more time with you. But thank you so much for telling me now. Something like that. You have to find sentences to close off a conversation very politely and appropriately. Okay. Lastly, for me, I think verbal skills are as important as non-verbal skills. Okay, I can be listening to the person, but just fiddling with my phone or fiddling with my computer, finishing my notes, that gives a negative message. I'm sorry, we are in an IT world now where documenting history is very important as you're talking to a patient. But I find it very difficult. I really like to talk to my patient first, look into their eyes, listen to them, show them appropriate verbal response, sympathy or whatever. And then I sit down and write my notes. I might jot down a few points in between, but not fully on my computer as they're talking to me. That is an absolute no for a good communication skill. Yeah, okay. So practice that. Be appropriate style of questioning. No leading questions. Always talk about open questions, no closed questions. You have no, a closed question is something where you ask and there's only two answers, either yes or no. We avoid that as much as possible in communication. So as much as possible, open question. So you told me about your fever. Can you tell me something more? When do you get it? How bad is it? Did you ever measure it with a thermometer at home? Things like that. Don't say, is your fever 38? Above 38? No. It will be a yes or no. So don't give that yes, no, closed questions. Make it open questions. Listen carefully using non-medical jargon. Okay. And then signposting. Signposting is very appropriate. Does anyone have an idea of what signposting is? I'm going to finish. This is my last slide actually. Yeah. Any questions, guys? I'm just checking whether you guys are listening. What signposting? What's a signpost? I don't want to catch Abdullah all the time. Can I ask Azman?
Is signposting like telling the patient what you're going to ask beforehand? So like, okay, next I'm going to ask about something.
Exactly. See, suppose you're driving, right? You see a signpost showing in the roundabout, and it tells you if you want to take a turn to Lambakanan, go left. If you want to take a turn to Rimba, go right, something like that. Yeah, signpost is something telling you what's coming next. So as you talk to a person, you say, okay, thank you so much. You told me all about your medical history. I'm going to move on to your social history. I want to ask you some questions about where you live, what's your job, do you smoke, things like that. So I'm moving on to social history. So you actually tell the person, I finished one part, I'm going to the next part. So that's signposting. Okay. So telling them in advance that you're moving on from one part of the conversation to the other. So signposting is very appropriate, but use it only in places where you think you're completely stopping one part of the conversation and moving to a different topic in the conversation itself. Okay. Body language, yes. If you sit comfortably facing each other, that's supposed to be the best word. I wish I could show this. This is how I normally show patients when I students when I'm teaching. Sitting across a person, almost similar, like knees to knees, hands facing in the same way. You don't have to be close to each other, but in the same direction. They say promotes good conversation, good, what should I say, rapport. It builds rapport when you are, it's like your body, you're telling with your body to the person, I'm all yours now. I'm listening to you. I've turned myself to look at you. My eyes are looking into your eyes. My whole body is now towards you. So actually you are my focus now. You are the most important person that I'm going to talk to for the next few minutes. So body language is very important. Facial expression. You can't sit there and say, oh my God, I have another 5 patients and this one is, you can't have that expression. I'm sorry to say, we have to be actors sometimes. Facial expression is very important to generate good conversation and rapport. Eye contact, yes. If I keep talking to somebody and just look out my window or look at my computer or look at my phone, that's the strongest body language to say, I'm not interested in what you're saying. Okay, just get on with it. Just finish what you have to tell me so I get on with what I have to do. So eye contact generally tells the person you're listening very carefully. You are actually taking in everything they're telling you. So maintaining eye contact is nice. Of course, with cultural aspects in place, you can't keep staring just because she's very pretty or whatever. Yeah, so make sure your eye contact is not too glaring also, acceptably. Okay, all right. Maintain good eye contact, polite and respectful. I've known patients who sit and stare at you so much so you forget what's the next question you want to ask them. Okay, it's very unnerving if somebody keeps staring non-stop. So look at them politely, but keep eye contact. Is that okay, guys? So my last slide is the references. Please have a look at the King's College one. That's a wonderful online history taking introduction. It's beautiful. Another one that I liked was the UK Doctor History Taking Examination. There's a lot of practice there. Please make sure you find a few and practice. Remember, clinical skills do not come by just watching videos, do not come from listening to a lecture. They come by practice. So you first practice among friends. So you get that network of questions into your mind in a sequence, and then be adventurous. Go into the ward, pick a nice patient and talk to them. Just simple things, just history. Remember, you want only upper respiratory, never mind. Just ask about cough and cold and fever, maybe in a respiratory ward. The best thing would be to sit in a GP clinic. If you can, if you have time, go into one of the, you are welcome to come to JPMC and you can sit down with a flu patient and talk. But of course, we will wait for these COVID restrictions to be lifted off. I invite each one of you to come over. I can give you sessions there one-to-one where you take history and then you go through the sequence of what's very important is fluidity, how you do it in a systematic way. That's very important history taking. Everyone knows what to ask. All the points will be there, but don't jumble the order. You have to do it in a particular order. That's very important. And we look for that in the exam. We look to see how calm you are and how you sequence your thoughts, how you systemize your thoughts, and then how you collect information, put that into sequence, and then summarize. We definitely see how you summarize and how you finish. Okay, guys, I think I've given you all the tips of how to pass your SK exam. Any questions at all? Now I'd like to see some mics turning on before I finish, yeah?
Hi, Doctor. I have a question.
Yeah.
Yeah, I was just wondering, because you mentioned, well, you raised the issue about certain patients being quite difficult, with wanting, an immediate cure or an immediate relief for their symptoms.
Yep.
Just wondering, what is like the ideal thing that we're supposed to do in that situation? I imagine you must have been in that situation. So like, what did you do or what would you do in that situation?
Hundreds of times, yeah. So when I first came to Brunei, I think much more before you guys were born also, 1993. I'm sure none of you were born that time. Okay. So the culture at that time was, if you have a sore throat, you have a cough, even mild fever or no fever, you get antibiotics. Okay, so they come in and say, Doctor, minta ko antibiotic, batuk ko. Sudah 5 hari sudah batuk. It took us a long time. It took us more than 10 years to change that culture, to tell them that common cough, common running nose, common sore throat does not need antibiotics. And I must say, over a period of time from 1993 to now, that culture has changed in Brunei. But that culture is now practiced by parents in children. They bring a baby and they expect you to give antibiotics. So now the tough point is not prescribing antibiotics for children. The adults are okay to a certain extent. They accept, but I know some clinics, they give off antibiotics very easily. They'll say, I just finished the course. The cough is still there. For them, I think patients interpret upper respiratory tract infection should vanish completely once they finish the antibiotic. They don't realize the cough can be residual. A productive cough can become dry and then it will stop. They don't realize that. So I have to explain that to tell them, see, you took antibiotics when you had high fever, you had green phlegm. Yes, your respiratory system was fighting the bacteria, it was producing phlegm, but now how is your cough? They said, oh, now it's very dry, doctor, no more daha coming out, it's dry. So I catch that point and I tell them, see, that's your body saying it's recovering, it's healing. So the lung is now showing signs of stopping the cough. So you don't need anything else, maybe just a lozenge or maybe a sip of green tea or a sip of lemon tea or whatever is soothing to your throat. So you have to really explore what they want. Is it the first course of antibiotics they've come for, or they already had antibiotics? And why do they feel this particular cough will go away with antibiotics when there's no sign of infection? You have to tell them the definite sign of infection is fever. The definite sign of infection is it's affecting you so much that you can't do your daily activity. A mild fever, one spike is only viral. If you have one spike to 38, 39, and the next day you feel like you're fine, tell them that is viral. But if the fever persists, the symptoms are getting stronger and stronger, like the phlegm was whitish at first, then it's becoming greenish yellow, it's becoming more copious. Now it's getting to a point where you have shortness of breath, your nose is fully blocked, you can't breathe properly, both the nostrils are blocked, high fever, yes. We think of sinusitis, we think of throat infection, look at the tonsils, whatever. So it's all a matter of listening, explaining, and I think patients nowadays demand explanation for every symptom they have, and they need to know why you made the decision not to give an antibiotic. So that you have to be very strong. You have to be consistent. You have to tell them, no, definitely you don't need antibiotics. And I'm sure not every doctor does that. So sometimes if they're unhappy, they'll do doctor shopping. They'll go to the next private clinic that's open and get it. But your role is to make sure you don't prescribe unnecessarily. Does it answer your question, dear?
Yes, thank you so much, doctor.
It's a big challenge not to prescribe antibiotics and reply. I find my Caucasian, because now I work in JPMC, I worked 17 years in MOH, and now on the other side, we see a lot of Caucasian population with no, what shall I say, no bias, but they accept. In fact, you give them an antibiotic, they look at you like, what's wrong with you? You know, so they accept. They will say, no, I just came in for some lozenges, good lozenges and some vitamin C. They'll happily go away home with a sore throat with no antibiotics. But our patients are a bit like, do you think an antibiotic will help? They'll try to make you give it, but as long as it all depends on your intuition and your observation and what findings you find. Suppose it's like I had a minister who's flying to Geneva for a talk, right? He was going to present about Brunei in Geneva in the WHO conference. And he came to me with a side sore throat, mild fever, and I think whitish phlegm in the fall. Yeah. He's not a smoker. He has no other thing, but he's very anxious not to get a sore throat in Geneva, right? What would you do? Would you give him antibiotics or would you say, no, you're fine? This is an ethical question, actually. Any guesses, guys?
I think you cannot give antibiotics before the infection. I'm not sure.
Mm-hmm. Mm-hmm. Any other guesses, guys? I see Zana, I see Hasman, I see Faiza. It's so unfortunate. I can't see your wonderful faces. Don't worry. I know some of you are in your hoodies. The last class, I saw half of them in t-shirts and wearing the hoodies on top. It's okay. I can see you as you are. Okay, you're tired, huh? No sound at all. Okay, let me give you the answer. Remember, this was a minister. I told you he was a minister. He's going into a world level conference. And there is something called VIP medicine, right? You cannot offend these people. You cannot oblige wrongly also. So there's a midway. So I told him, okay, sir, I know you're going for a very important meeting. Your voice is very important because you are the presenter. And I know you're anxious that you might lose your voice during travel. The virus might get worse. So I'll do one thing. I'll give you your lozenges. I'll give you some throat gargle. I'll give you some vitamin C. That's all that you need to use actually. But I'll give you a course of antibiotics, which we call delayed prescription. Okay, I told him it's called a delayed prescription. You have it in your bag, but you will take it only when it's deemed necessary, right? So you have to do a self-examination of yourself to decide whether you need the antibiotic or not. I'll give you the red flags. If there's high fever, the voice is breaking, or there's difficulty in swallowing, there's pain when you swallow, and you open your mouth and see in the mirror, it's fully red and raw, the throat, the posterior wall, okay, then you start the antibiotic. So we call it a delayed prescription. So in a way, he's going to a country where he won't be able to access a GP immediately. Most probably he'll be busy with enrolling into the WHO conference, meeting people, getting his accommodation settled, travel and all that stuff. So he'll feel safe if he has the antibiotic with it. So those are the conditions where you might have to give a delayed prescription. Is that okay? And it's acceptable actually. It's acceptable by General Medical Council rules to give a delayed prescription where you think the illness might progress and it might affect that person's particular daily activity. Imagine this person's daily activity now is presenting in an international conference. So you have to keep that in mind. You have to be a bit sensitive about that.
So does that mean that we're giving the patient the trust in taking the medicine only when necessary?
Yes, you have to teach them exactly what are the red flags where he'll say, okay, now I open the packet of antibiotics. You have to tell them exactly.
Won't there be a chance that the patient will misdiagnose themselves, or if they're a
Yes.
worrier then?
Yes, but at least you're justified in saying you explained everything and you've given him clear instructions on when to start, when not to start. But if he misuses it, that's his lookout. Yeah, that's why I said it's an ethical question. There's never a right or wrong in an ethical situation.
I see. Thank you, doctor.
Okay, guys, thank you so much. I wish I can see all of you. And I think you all are very shy. I'll come there someday in UPD and catch you up. Any questions, email me. You have my email. And this PowerPoint, I'll just send it to Pfizer. Maybe, or you recorded it, right? I don't know whether you got the whole PowerPoint. I'll send it to Pfizer. Is that okay?
Yes.
Thank you, Abdullah. Thank you for setting in the Zoom at the last minute. Thank you so much. I will polish my skills before the next session, inshallah.
Inshallah. Thank you so much,
Thank
doctor.
you. Thank you. Have a nice day. Be safe.
Thank you so much, doctor. Have a nice day.
Thank you, doctor.
Thank you.
Thank you, doctor. Have a good day. Thank you, doctor.
Thank you. Nice to hear all your voices now.
Thank you,
Okay.
doctor.